All right. Oh, it is 8 a.m. So we will get started. Um, so we'll make this big. We'll make this. There we go. Yes, there we go. I am technologically capable. So I'm Megan, and I'll give our first two cases for the day. We're going to start with a 5-year-old neutered male Bombay cat. Um, This kitty presented in mid-March or so for a history of ocular cloudiness and increased tearing in both eyes. They note that this patient does not have a recent travel history, which is interesting, the use of the term recent, and is an indoor-outdoor cat. And then also a little bit of weight loss, but that's all that was really noted on presentation. Um, they found a retinal detachment, complete bullous retinal detachment of the right eye, which is the eye we ultimately got, and a bit of uveitis. Also a lower lateral palpebral conjunctival mass of the right eye. They did a bunch of testing initially and was negative for toxoplasma, FIV, FELV, cryptococcus, coronavirus, and a mild positive for Bartonella. It looks like on a single titer. Um, and they did some treatments for a while, and he wasn't really getting better. So they submitted something called a West Coast Feline Fungal Panel. Um, and that was pending upon submission of this eye. They did an abdominal ultrasound, which showed mild hepatosplenomegaly, or not mild, just hepatosplenomegaly. And then the right eye still wasn't getting better, and they ultimately submitted it. It also had glaucoma. So that's the whole deal. Here is our gross view of this guy. So we have a hemisected globe, optic nerve is down here, cornea is up here. You can see that the cornea is a little bit thick and cloudy, so it could be consistent with edema. We've got a fairly opaque lens. They had noted this narrow anterior chamber, which we can see grossly as well. And then the main thing I want to point out is it's sort of low profile, but you can see some grossly visible thickening in the uveal stroma, especially up through here where the ciliary body is kind of thick and like a grayish tan. And then, of course, there's a big retinal detachment with some wispy shenanigans in the subretinal space and some cloudy gel in the subretinal space, and maybe the retina is looking a little bit thick, maybe a little bit of hemorrhage. So some interesting stuff to see on the gross. Let's see. I never do that. Well, wait, where did our buttons go? They're gone. Okay, well, that works. All right, here we go. Now we're at the scope. Let's see if we can do a reasonable subgross here. So here's our eye. Most of what you notice in the subretinal space is just this homogeneous pink stuff, which corresponds with that gel we saw grossly. Usually something that gels up, especially on formalin fixation, implies a really high protein content. So this is a really high protein fluid in the subretinal space. We do see, well, maybe not so much in the subgross, but maybe evidence of that subtle kind of low profile uveal thickening. We'll take a look at that closer in a second. And I mentioned a conjunctival mass originally, and there's at least a little bit of a bump out here in the episclera, which is interesting to look at too. So let's take a closer look. We've now rotated the cornea to our right, so just to orient you, here we are. We do have an additional section out here, so which we'll focus on that one probably. Look at that one. But anyway, so our cornea is out here on the right. Um, if we look at pretty much any of our uveal thickening and or this episcleral bump, it'll look pretty similar. These are inflammatory cells. So we've got a good number of macrophages, we've got a good number of neutrophils, and we've got some lymphocytes and plasma cells besides, and they're all kind of just admixed. We don't necessarily see like good pyogranulomas here and there, and it's a similar inflammatory population over here in the uvea. Here you go. So macrophages, neutrophils, lymphocytes, plasma cells causing kind of a thickening. Um, we can confirm our retinal detachment way over here. Here's our detached and kind of sad retina. With a little bit of outer atrophy. And that's mainly what we're seeing. So this case is suspicious for something infectious. In a cat in particular, if you have that kind of jumbled macrophage, neutrophil, lymphocyte, plasma cell infiltrates in the uvea, sometimes it'll even cause an overt mass effect. This section is actually pretty darn good. For example, at least sort of thickening, if not mass effect in this case. I would say that our top differential is histoplasma. But one of the weird things in this case is they said no travel history, at least no recent travel history. I do wonder if that means that sometimes in the past there was travel history. But this patient came from California, so histoplasmosis is not necessarily high on our list per se, but did a GMS anyway. And if I were smart, I would have put a dot. Hooray. Thank you, past Megan. You're so kind. I find oftentimes out in the free-floating macrophages in the intraocular spaces are sometimes the best. So for example, here we have these little oval guys. One of them is maybe exhibiting a narrow-based bud there, or maybe two narrow-based buds even, kind of the Mickey Mouse ears effect. I don't know. We have these little guys. And then if you look in the uveal stroma, they are here and there. And at that point, I didn't put a dot for myself, I don't think. Do I have a second dot? Am I that lucky? No, I only have the one dot. So we could look for the ones in the uvea, but I suspect we'll be looking for a bit. Um, so sort of this 2 to 4 micrometer diameter, maybe round, but often kind of oval-shaped structure that is GMS positive and is exhibiting narrow-based budding is strongly suggested for histoplasma. I'm not gonna be able to find them quickly. They were in the uveal stroma also, believe me. So the fungal panel came back and also was positive for histoplasma on that. So even though this patient came from California, this was a case of ocular histoplasmosis in a kitty. And I looked, and apparently there have been cases described around like the LA area, for example. So I think a good example of how sometimes geographic location can clue us in on what infectious etiologies you might consider, but always keep an open mind, I would say. And fungus is probably going to take over the world, so you know.
Considering that the test cannot differentiate between blasto and histo,
It's a good point.
I wonder if there are other fungi that could be present in other geographic locations that might cross-react as well.
Yeah, that's a good point. Yeah. It's important to note, I think, especially the urine antigen, the antigen that they are detecting with that test is literally the same antigen between blasto and histoplasma. So there is like 100% crossover. So definitely keep that in mind on the clinical side of things.
I ask, is the West Coast panel the same as the Mira Vista?
Good question.
So I Googled it, Dr. Clemens
Incredible.
talked about it because
Thank
I
you.
had never heard of it. And so the feline fungal West panel targets histoplasma antigen, cryptococcus antigen, and coccidioides antibody.
Oh.
And it says typically requires a 1/2 ml of urine or a 1/2 ml of serum.
It might be still
I
the
think the
same
West Coast
crossover.
air
Yeah.
goes to differentiate between adding blasto versus adding coccidioides just because of
Yeah.
geographic location, but I don't think it's
Am I still cross?
nothing different than
Yeah,
it's
okay.
just
I was just-
the mixture of the organism that it has for you.
You said it was negative, even though it does test for histo.
The patient was hit positive for histoplasma.
Oh, it was.
Positive, yes.
Sorry.
And also another thing to consider is it's not uncommon for these animals that have ocular fungal disease in general, not just histoplasma, to test negative in systemic testing, just because sometimes they are done with a systemic part of the infection and the organisms are still inside the eye, which is an immune privileged sort of well contained site, and they might not have circulating antibodies at that stage. So a negative result doesn't mean much.
That makes sense. Thank you.
I could have been looking while we were talking.
And sorry, go ahead.
All right. The antigen is the target for vaccine development because it's conserved across species.
Yeah, so
Ah,
that is kind of interesting, actually, that who knows what might be in this eye.
Yeah, and it's interesting that it's labeled as, organism specific, since
I know, it's
Right.
kind of weird that they market it that way.
So Dr. D comment here that there are several cases in California, cases of histoplasmosis in California in the database. I plotted these feline cases in well, from a while ago, like 2016, 17, and there were outliers that were in non-endemic areas. Like there were a bunch in Florida, there were a few in California. I usually joke that I think the ones in Florida are the people from Ohio that retired and moved down south.
Which is
and bring
probably
their
true.
kids.
Recent
Yeah,
travel history,
I
right?
mean,
I wondered where this cat came from.
yeah,
Exactly.
They do say recent travel history, Dave.
So like, oh, is he bought in Kansas? I don't know.
yeah, right.
Maybe that one's not necessarily great. Anyway.
I thought it was a joke, but every time I say that, people are like, "Oh yeah, that makes a lot of sense." Which
There were some I know, it's like, they never left it in right, I still do.
Oh, that's why it's hidden. There we go. All right.
then can you and go back?
Oh, yeah, that. Wait, go back to
Go back to the PowerPoint. Enable editing up there. Right.
okay. Yes. Oh, and I did helpfully write specifically what methods of testing were positive for the on the bottom for myself, so and for everyone else. So there you go. I'm glad Past Megan did that for me as well. Good job, Past Megan. All right.
Did you comment on the possibility of systemic involvement in that report?
Always, yeah. Patient was losing weight. So yes, the question was, did we comment on systemic involvement or the possibility of systemic involvement in the report? Yes, absolutely. With ocular manifestations of fungal disease like that, the concern is always that it's systemic mycosis. There's probably like an extremely small subset of cases that's like local inoculation from trauma or something, but in all likelihood, a lot of these are ocular manifestation of systemic disease. So you always want to go looking for that. Absolutely. Okay. The next case. All right. I laughed at my own crappy image. Anyway.
It's so cute. This is
Yes, you're right. I laughed at my own crappy art. Anyway. So there's no gross photo available for this case, as you can see. We're looking at a 2-year-old intact female conic horso. So this patient also lives in California. And this patient had glaucoma of the left eye, and peripheral retinal detachment, versus something else, which I will withhold for now. On gross examination, I will try and paint you a word picture, with someone else's words. In the vitreous, there was a thin, tough strand of tissue spanning the ventrolateral ciliary body pars plana and connecting to the posterior lens capsule. Very interesting. And the vitreous was thin and the globe was ophthalmic, and that's about it. All right. Whoops. Here we go. And that. Actually, let's try for the subgross first, just to show what's going on with this case and get everybody oriented. So this case is what we lovingly refer to as Swiss rolled. Essentially, if a globe gets a little bit ophthalmic to fit in a mega cassette, but is like not as big for an XL, we'll make a little releasing incision in the sclera and then kind of overlap the ends. So that's why it looks the way it does. And it's a pretty quiet eye overall. And maybe the thing in the other section is more important. So this is just an additional section of the globe. Let me try and get it oriented again. So we have the cornea up here and it's curling around on itself like that. And we do have a little bit of lens in the middle here. And maybe what is visible is down here, sort of right where pars plana becomes choroid, maybe roughly around the area of oris ciliaris retinae. We have this little nubbin of collagen. And this section does correspond to that thin strand that they mentioned on gross exam. All right, let's find it again. Here it is. So, chaos. We have a little bit of inflammation in our choroid. And we have this sort of jumbled up retina, which is a little bit atrophied and maybe like a very focal detachment or a little pool of proteinaceous fluid, something along those lines. And then we're catching our little strand of tissue right here. And it's a thin strand of collagen, so it kind of comes in and out of plane of section funny. And when we section across it, we get this sort of oval-shaped band of collagen. So that's kind of cute. And then you'll remember that they said that this strand extended grossly, a little bit of hemorrhage too, by the way, extended grossly from this area in the globe all the way to the posterior lens capsule. So this eye is overall quiet, and you're all like, I don't know, the lens is not that bad, right? Except for if you look here in the equator of the lens,
Failed.
impaled. We suddenly have this little guy just embedded in there.
So quiet.
It's so quiet. I had a fun time with this case. I was like wandering around and I was all like, huh, this is like a weirdly like quiet case. And then like suddenly this obligatory polarization because it's pretty. It's very bright.
Ooh. Ah.
Very psychedelic.
So this little guy with its sort of polygonal, thick-walled spaces and kind of probably dead-ish tissue inside those cell walls is a little piece of plant material. Could be like a migrating grass on, could be a thorn. I am not enough of a plant pathologist to tell you exactly what sort of plant structure this might be, but I can tell you it's a piece of plant. And so probably this little guy penetrated right through the globe and moved right through the vitreous into the lens. And my guess is it was a pretty acute penetrating trauma or so because of how quiet it is.
Did a fragment of it outside too?
Yep.
Wow.
Here it is out here. Isn't he cute? Adorable. Couple of macrophages walling it off too here. So, yeah, and the little piece of information that I withheld is they specifically said versus vitreal foreign bodies, so they were worried about it on their imaging as well.
What was the duration of, did they say?
They said duration 10 months, so yeah, I mean, maybe it just walled itself off and that's why it's so quiet.
Yeah.
I mean,
Sterile
And this, yeah, I was gonna say that this one, because we often find bacteria, we find fungi with,
yeah.
this one seems to be clean. I don't know if that had,
It was a green thorn.
it was a green,
Instead of a
a
woody
big
one.
decaying one, yeah.
Yeah.
So I wonder if that has anything to do with how quiet it was.
It was a potted plant grown in
That's-
hydroponics.
So it was like
Yeah.
inside the plant, it's like well taken care of, clean right
Yeah.
literally.
Any signs of any other entry points in the back or just the,
This at least is the only thing that got captured.
right? But nothing in the episclera or,
Nah, I think it's because we're kind of like out of plane. I was we
Makes sense.
could go deeper and see if we get more of this track.
curious,
But yeah,
in here.
yeah.
Did we say where it was ventral or dorsal or where it was in the globe?
Good
Gross
question. We said ventrolateral. Which so the question is, did we say where the penetration site or the strand was in the globe? And the significance of that is if the penetration site or the point of entry is a little bit more ventral, that tends to suggest that it came up through the oral cavity. And if it's a little bit more dorsal, it may suggest that it came from like outside the head. So ventrolateral, maybe it came in through the oral cavity, you wonder. So a simple case.
I
And
think
that
we could
was-
have put malicious spines on that adorable plant
Mhm.
and turned him into like an evil little plant.
It's not his fault. He's just trying to live. Anyway. Yes, so plant foreign body. Oh my gosh, I forgot a bunch of other stuff in this case. So there was also
Wow, you went for the most important thing.
I did go for the most important thing.
Maybe it was a blind eye and that's why it ran into the thorn.
Trauma to a blind eye. So also up here in the anterior segment, I forgot this whole process, man. This is a bit of an older case, so usually we would expect an open ciliary cleft, and we would see these individualized pectinate ligaments. We'd also see this sort of net-like tissue back here, which is tracheal meshwork, and we don't see any of that in this case. It's all closed up. This patient did have glaucoma and buphthalmus. So there's an iris-like tissue that kind of runs over that iridocorneal angle and contacts sort of the tapered end of Descemet's. And then maybe you could imagine that some of the aqueous outflow tracts are a little bit too far posterior. They should be more maybe level with the iris base. So there's a possibility there. I don't know if I was happy with scleral venous plexus hypoplasia. The vessels scleral venous plexus aren't super obvious at this level though, so there is that. So this is what anterior segment dysgenesis can look like, or at least what we currently refer to as anterior segment dysgenesis. So essentially this can be a malformation, congenital anomaly in the iridocorneal angle that is not always bilateral. So we use the term anterior segment dysgenesis to distinguish this presentation from gonio-dysgenesis, which is pretty much always bilateral. But we do have some cases that we call anterior segment dysgenesis and that present with a juvenile onset glaucoma that are bilateral. So it's not always bilateral, but could be basically. And this patient was 2 years old and they said a 10-month duration. So yes, actually there may have been underlying juvenile or early age onset glaucoma and then also a plant foreign body in this case. There we go. I was all like, this is a very short case for rounds. There was more. It was a twofer. Anyway, back to this. Whoops. All right, now I've presented this case. Does anyone have any questions? Okay, then I will shift. The next case is Gillian.
Okay.
Not as subtle.
Oh, I was gonna actually wait to change the slide, but oh well, okay. So this is a cat, a 9-year-old cat with a very it came with a very detailed, very long history. It's 9 years old. It is a spayed female. Essentially, she was diagnosed with bilateral panuveitis and glaucoma, so elevated IOP in both eyes. This eye, the right eye, had chorioretinal lesions. Chorioretinitis is what they diagnosed. And then both eyes, I think, actually they say that was both eyes had chorioretinitis, was worse on the right, this eye. And there was also inflammation in the anterior chamber in both eyes, but worse on the left eye, the other one. Long story short, we got both eyes from this cat. They did a whole bunch of screening tests and imaging on this cat and found nothing. So PCR testing for herpes virus, coronavirus, leukemia virus, Bartonella, cryptococcus, toxoplasma, FIV, blastomycosis, coccidioides, cryptococcus, and histoplasma were all negative. Thoracic radiographs showed no evidence of metastasis. The cat did have some renal problems, and so she had some mild kidney disease. They were, I can't remember how they treated the eyes, but then suddenly this right eye developed this lesion. So very sudden. So the clinicians diagnosed this as acute bullous keratopathy. So the emergency clinicians who first saw this cat for this problem exactly thought that the eye had ruptured, but actually the eye is not ruptured. This is literally a focal, like severe dilation and corneal edema, say basically corneal stromal edema. So we would call this hydrops, but clinicians call this acute bullous keratopathy. So because both eyes were blind as well. So because both eyes were blind, they decided to enucleate both and submit them to us. This is the right eye. Unfortunately, the clinician said that as she was trying to get the eye out, she nicked the sclera, so it's a little bit collapsed. So grossly, it's not the prettiest specimen, but here's what it looked like clinically. So you can see there's relatively normal cornea behind this blob, this like water balloon. And the iris looks a little bit, I mean, it looks probably fine, I would say. And so then when we got it, this is what it looked like. So that sort of clear lesion looked a little bit more cloudy here. And then everything's all jumbled up here because it was collapsed. But we did note this strand of material coming from the lens up to that area of the affected area of the cornea. So there is that. So as I said, we got both eyes. The other eye was not as fun and exciting, so we didn't take a gross photo of it, but I'll show you that one, the histology of it as well. So let's. We got two sections of the globe. And as I said, it was collapsed, so it's not as pretty. Sorry. Okay, so here's the cornea, and that's the area of that water balloon structure. So then we move back a little bit, and we have the iris on both sides of the globe. Here's the lens. And back here, our amazing histology technicians sampled the optic nerve, which was lovely. And we have some of the retina to look at. Here's probably close to where that's the clinician had nicked it during surgery. There's a little bit of hemorrhage here, which I think is acute hemorrhage, probably associated with that iatrogenic lesion. So let's go ahead and. So what we have here is Descemet's membrane comes along here and it's discontinuous. So we have a break in Descemet's membrane, and then you can see the corneal stroma is relatively normal over here. It's kind of dark pink, it's kind of lamellar. And then as you head up into that area of affected corneal stroma, it just becomes very pale. And that is profound corneal stromal edema. It is also ulcerated, so you can see the epithelium is present here, there's a little bit here, but then it becomes absent. So there's a corneal ulcer associated with this area of affected cornea. Here's more of Descemet's membrane, so it's discontinuous and kind of coiled up, and it's also separated from the deep corneal stroma there. I think there wasn't much peripheral corneal stromal vascularization, so I really think this was, which would be consistent with a very acute process. So whenever you have corneal stromal edema, it's always good to think about the health of the corneal endothelium and try to assess it and decide whether it was normal. I felt that this was maybe a tiny bit attenuated, so maybe that was contributing to some corneal edema. Here's a better example of attenuation, where we have flattening of the corneal endothelium with no evidence of cytoplasmic vacuolation. So normally the corneal endothelium drinks the liquid out of the corneal stroma and keeps it relatively dehydrated. So they have the corneal endothelial cells typically have some cytoplasmic vacuolation, which was a little bit more apparent here, although that's kind of a flat mount of the corneal endothelium. But anyway, so I wondered if there was some corneal endothelial attenuation, which may have contributed to corneal stromal edema. And yeah, so trying to think here. There's a little bit of hemorrhage also associated with this. So basically, this lesion is a bit mysterious, and it often is in when clinicians diagnose it and when we get globes. Sometimes, if it's not too severe, they can actually do a third eyelid flap, where they suture the third eyelid up over the cornea, and eventually the edema will resolve. And so they can save the eye that way. This was a little bit too pronounced, I think, to do that. So this eye had other history, which is puzzling when we look at the histology. So they talked about material in the anterior chamber. It's really kind of hard to assess that in this collapsed globe. There's a little bit of hemorrhage around. There's a little bit of iridoid stromal hemorrhage, which could potentially be associated with the iatrogenic scleral laceration. There was maybe a minor cataract, but it wasn't too pronounced. And then when we move back, so they did say that this eye's IOP was 36 at one point, whereas the IOP in that left eye was 62. So this one had more pronounced elevated IOP. When we look up in the anterior segment and try to figure out why it's elevated, it's a little bit hard to tell, especially with the collapse of the globe. Sometimes it's hard to assess the relationships of the iris and the ciliary cleft and the lens and that kind of stuff. But the anterior chamber does seem to be a little bit narrowed here. And I admit I was kind of scrambling to come up with reasons for an elevated IOP in this eye. The ciliary cleft is here. The meshwork is a little bit narrowed to collapsed. There's no fibrovascular membrane to explain that. And that is true in the other areas of that we've examined in the anterior segment as well. So the ciliary cleft is maybe not so apparent. The iris is awfully close to the posterior cornea. So it was a little bit tough to explain that. In an eye that's more pristine, we would look at these lesions and when we find glaucomatous degeneration, which means atrophy of the optic nerve head and loss of retinal ganglion cells in a cat, we might suggest aqueous humor misdirection syndrome, which is basically the only thing I felt like I could propose in this case. However, most of those cases clinically have clinically observed anterior chamber narrowing, or a shallow anterior chamber. And that means that the iris and the lens are pushed anteriorly. And we think the cause for that is that for some reason, and that's the real question, that aqueous humor is being produced at the ciliary body, and instead of going anteriorly through the pupil and out into the anterior chamber and the outflow tract, it goes posteriorly into the vitreous, and then it pushes everything forward. And that is similar to something in humans, a condition in humans. I don't think we've ever really proven that that is exactly what's happening, but that's our best guess at these cases. In this case, it was really hard to confirm that because they never noted a shallow anterior chamber clinically that they shared with us, at least in a pretty significantly detailed history that we got for this case. So I really am not quite sure about the glaucomatous degeneration. The other thing that this eye has is, well, when we look down here, the optic nerve is atrophied and a little bit gliotic. So this is atrophied and gliotic. And then we have loss of retinal ganglion cells. So they should be up here. And the other thing we have is intermittent, there's some ganglion cells. Of course, they're going to show up and make me a liar. But what we have is the inner nuclear layer that's present over here in the far corner, but then it's absent. So we do have some interesting inner retinal atrophy. And then as we move along, there are some other areas where there is some retinal atrophy. Let me see. So it just has sort of an odd pattern, like in this area, sorry. We just are lacking that inner nuclear layer, and then also the inner and outer segments of the photoreceptors are atrophied. So this has some kind of peculiar retinal atrophy. One thing that I could not explain, another thing I could not explain, I should say, in the history was the clinical history of corneal retinitis. So as a pathologist, we look for inflammation. I found no inflammation in this eye anywhere. There was nothing, there was no uveal stromal inflammation. There was no ocular chamber inflammation. So I had a really hard time explaining that. I did wonder if the areas of retinal atrophy maybe were interpreted as chorioretinitis clinically. But I really don't know. I don't have a good explanation for that at all. And they did say that was bilateral, so we'll eventually get to the other eye. So my diagnoses for this eye were corneal hydrops, which is consistent with their diagnosis of acute bullous keratopathy, unknown cause. In other cases of this condition in cats, a decent number of them have a history of systemic treatment with steroids. This cat did not have such a history. I felt in cats with areas of retinal atrophy, we do occasionally propose that blunt trauma may have been involved. And maybe blunt trauma could have caused rupture of Descemet's membrane with ensuing bullous keratopathy development or corneal stromal development. But nothing really made me feel really good about this case. It was kind of mysterious. I just thought that clinical photo was awesome to share. So the lesions in this eye were a little bit mysterious. The other one is a little bit more straightforward. So let's go ahead and jump to that one before I show the diagnoses. So I think grossly in this eye, we noted that the iris was a little bit thickened. Yeah.
Oh, when did they first diagnose that it was non-visual?
Oh, good question. About probably 3 months before we got the eyes. Yeah. Well, wait, sorry. What was your?
When did they diagnose it as being blind?
Oh, about 3 months. And it's possible that it had been blind longer. But that's when it was first seen by an ophthalmologist, I think, or maybe even a vet that I'm not sure if it was an ophthalmologist. Okay. So yeah, just a bunch of sort of weird lesions in that eye that were tough to explain, like to give definitive reasons for. This eye I felt much better about. So this is the left eye. So on the subgross, cornea is off to the left here. Here's an iris that's quite thickened. The iris on this side is a little bit busy on its anterior surface, and then there's some busyness in the ciliary cleft. And there was glaucomatous degeneration of the, oh no, actually there was not. Even though this eye had a higher IOP, I didn't really feel like there were much great lesions in the optic nerve and retina to corroborate glaucoma, which I'll show you at higher mag if I remember. And then also, here's another extra slice where we have more of that like stuff happening in the ciliary cleft. So this one is much tidier to present. And we're just going to focus on this iris leaflet. So even from this mag, so there's some sort of infiltrate in this iris stroma, and it also occupies the ciliary cleft, kind of lines the beams of the trabecular meshwork, the ciliary cleft and trabecular meshwork. And even from outer space, as we call it, as the lowest mag that we have, you can start to see that some of these cells are enormous and have gigantic nuclei. So as we go higher mag, we have an abnormal cell population here that's quite pleomorphic. So we've got some really gigantic cells with multiple nuclei. So there's really marked anisocytosis, which is variation in cell size, and anisokaryosis, which is variation nuclear size. And just as we go higher mag. So these are beautiful cells. Some of them have very faint pigment, like this guy right here has some brownish pigment in the cytoplasm. And there are probably some mitotic figures around. Here's one here, here's one here. So this is and here's another example of what we sometimes see, which are nuclear pseudo-inclusions. Here's another one here, which is presumably a very big floppy nucleus. And then in this section, some cytoplasm has invaginated up into, not technically in the nucleus, but pushed. Anyway, we think that's cytoplasm that we're seeing. Anyway, so that's a nuclear pseudo-inclusion right here too. So this is a iris melanoma. So we call this in cats a diffuse iris melanoma. This one happens to be poorly pigmented. And this is not unusual to see, but when we see it, it's certainly fun to look at. The ways that we prognosticate about iris melanomas is the extent of invasion. So is it in the ciliary body, which it was in this case, it did extend into the ciliary body stroma. Sorry, let me back up a step. They begin on the anterior iris surface, and then they infiltrate into the iris stroma. And when they are only in the iris stroma or when they're only in the iris stroma, that's the best prognosis. And then surgical removal is typically curative, and at that point, metastasis should not have happened. When they extend into the ciliary body, that means they're a little bit more advanced. And then when they extend into the sclera or the choroid, that is the worst prognosis or one of the worse prognostic features. Elevated mitotic rate, which is 7 or more mitotic figures in 2.37 millimeters squared, is worse prognosis and areas of necrosis. So this one was confined to just the anterior uveal stroma, so it has sort of the intermediate prognosis. They had thoroughly staged this patient and found no evidence of metastasis, so that's overall good news for the cats. And as I said, I saw no evidence of chorioretinitis or chorioretinal lesions. In this case, the choroid, the tapetum, we're looking at the tapetum here in the choroid, and the dorsal retina is looking pretty quiet and normal. And we look and we see very nice retinal layering, including retinal ganglion cells. And then we move back here, the optic nerve head looks pretty good. So I diagnosed this as glaucoma according, as per history, not confirmed histologically. and I also saw no other evidence of the retinal atrophy that I saw in the other eye. So this cat has some really mysterious lesions, and I felt like I couldn't really help them very much. At least I had the iris melanoma in this case, in this eye, to explain at least some of the stuff that was going on. But anyway, so this is what I have for the right eye. So that profound corneal stromal edema, hydrops with corneal perforation and rupture. It was because of how, because of Descemet's membrane rupture there and how loose it was, I called it a rupture. There was a corneal ulcer, blah, blah, blah. So the possible anterior displacement of the iris with narrowing of the iridocorneal angle and collapse of the ciliary cleft and trabecular meshwork is what we look for when we diagnose aqueous humor misdirection syndrome. And then multifocal retinal inner and outer nuclear layer atrophy, DDX, result of increased IOP, which is a little bit rare in cats. Usually when they have glaucoma, that doesn't happen very prominently versus other. And in my comment, I discussed the possibility of blunt trauma. Another possibility in cats is poor perfusion associated with systemic hypertension. They had measured this cat's blood pressure multiple times, I think, and it was relatively normal. So couldn't really explain it with systemic hypertension and then chronic secondary glaucoma. And then in the other eye, we had a poorly pigmented diffuse iris melanoma. There was a bit of a cataract. And then once again, as I said, glaucoma, which was secondary in this case, as per history, not confirmed histologically. So that was a little bit of a head scratcher case. I don't remember if we got any feedback from the clinician about that. But hopefully the cat is happy now with no eyes. Remember, she was blind before, so hopefully she's more comfortable now without glaucomatous eyes. So yeah, there you go. Mysterious case. Any questions? Okay, great. Next.
Ooh, okay. So we are going to finish up here. Last piece or two. First up, this is a 2-year-old male neuter domestic short hair cat. That came with the history of the owner noticing some watering and tearing overflow from the right eye on and off for about a month, and then noticed acute swelling and brought it in for examination. The clinician noted that the right eye was extremely ophthalmic and had absent PLR and menace. Fluorescein stain was negative, so there's no ulceration according to that. Cat was otherwise healthy. Blood work was within normal limits, and FELV, FIV was negative. Looks like they did some serial IOP measurements, and it continued to stay high. Unsure if they did treatment or not, but basically ended up with endotheliation. So grossly, we can see we've got a really, really big cat eye here. So our cornea is at the top. Grossly, it looked amazingly so, was the note from the gross examiner, given how big the eye was. And what we can see here is that here's our iris. And then you can see that the ciliary body here is just really stretched out. So you can really see all those plicae and how it's really stretched out here. The lens was subluxated, so it's no longer attached here anymore. And then if we come to the back here, there was this bit of like glob of like hemorrhage and goo, like glunk, I believe is what it was described as, on top of the optic nerve head here, and a little bit of hemorrhage in the vitreous, which was also a bit thin. So we will take a look at that lens. And oh yeah. We do see a little bit of abnormal shape here, this little bulging back here that we will look at histologically as well too. All right. So like I said, pretty large globe. So it's gonna be a little hard to do the subgross, but we've got our cornea at the top. You can see our little iris leaflets here. And then this really wide posterior chamber. Our lens got a little cattywampus in the sectioning, but it is still mostly here. We're missing a little bit of the anterior surface, but here there is a little bit of paleness to the posterior portion of the lens, which we will take a look at. And then here is a bit of hemorrhage in that material here in our retina. Looks like it's not attached to our choroid anymore, and we'll take a closer look at that. So I will start at the front with the cornea, at the left side here. And if we take a look here, sort of similar to Dr. Kleiman's case and hers, we've got some abnormality here in the anterior segment. Our angle here is kind of narrowed, and there's not really much of in the way of the cleft or the meshwork here. We've got some iris tissue that comes along and crosses the iridocorneal angle and attaches to desiccates. There's a little bit of some inflammation here, and we do have a membrane on top of the iris here, a little fibrovascular membrane. And kind of between that membrane and the iris stroma here is this eosinophilic material here that's sort of entrapped between the membrane and the iris. Presumably this is probably vitreous. So this is a good indication of anterior vitreal prolapse in section. It can be hard to diagnose anterior vitreal prolapse histologically, just given how sometimes things shift and move around. So it's really nice to see like an actual interaction with the vitreous with the front of the iris to sort of just confirm that. And so we can look at the other angle here, again, a membrane, which is some more of that anteriorly prolapsed vitreous, and then our iris-like stroma coming across here. All right, and then we'll head back towards our lens. Again, a little bit of sectioning artifact where our anterior portion didn't quite section very well. But if we stroll around to the back of the lens, we start to pick up lens epithelium that has migrated posteriorly, which is our early sign of cataract. And in addition to here, our lens capsule kind of splits here, and it's just filled with this eosinophilic, like collagenous tissue. And even like some degenerate lens fibers are in here too. So we've got some cataract and some kind of malformation there. And if we head back towards our stuff in the vitreous, we can see our hemorrhage here mixed with more vitreous-like material. Our retina is detached and it looks pretty kind of jumbly and atrophied. And we can notice on the anterior surface of our retina are these large vessels in this fibrovascular kind of membrane here. And we lose kind of our layering here. We got a few retinal ganglion cells, but for the most part, our outer segments here are gone. We've got a little bit of jumbling of our inner and outer stuff. Got a little bit of mineralization here. And if we take a look, normally our retina should have blood vessels in it. And we do see them. And the blood vessels should extend all the way to the periphery. So we've got a couple here. Here's again that sort of epiretinal fibrovascular membrane. And if we keep heading towards the periphery, we do keep seeing some vessels here, there, and they keep tracking. And then we hit this point here where you can see some of the blood vessels here, and then all of a sudden they just kind of go away. So blood vessels here, and then if you keep going, they're no longer here, and the peripheral retina gets a little bit gliotic. It's a little bit thickened here. And so we have an avascular peripheral retina that is also diffusely detached with an epiretinal membrane as well. I did throw on PIS just to sort of highlight those blood vessels. They give us a lovely little chromatic therapy this morning. So again, we can still see some blood vessels here centrally. There's some nice good ones here. And you can follow them out for a little ways. And then as you hit that peripheral retina here, they just sort of stop. And they are no longer there. Or were never there to begin with, I guess.
Can we look at the lens capsule?
We can. focus. So that little split. Cute and adorable. All right. So the features in this globe are fairly consistent with feline neovascular vitreoretinopathy. So this is a congenital condition where the features were pretty classic in this globe. So the peripheral retina, again, is avascular, and there's usually some retinal gliosis and that epiretinal neovascularization and hemorrhage associated with that. I think in this case, the blood vessels extended a little bit more peripheral than I've seen in the past. Sometimes you may only see blood vessels centrally and like not. So I had to go pretty far to find the avascularness to the peripheral retina, but it was still there. These globes can sometimes have other congenital abnormalities, as seen in this case, that we had that anterior segment dysgenesis. Usually these eyes aren't a problem until glaucoma develops, which is usually pretty early, probably by the time the patient is 3. We also had that anterior vitreal prolapse, which probably wasn't helping either. This is usually a unilateral condition, and we're not really sure what causes it.
Can I interject?
Yes, absolutely.
I almost wonder if it also had a component of persistent hyperplastic primary vitreous with that abnormality of the posterior lens capsule.
Yeah.
And so I don't recall seeing lesions of both of those in one of these feline neovascular vitreoretinopathy, but why not? You got one developmental abnormality, why not another one?
Why not others? Sure.
So that classic like posterior lens capsule plaque grossly with various cataractus changes and is a good feature of persistent hyperplastic primary vitreous.
Yes. Cool. So that was just a nice example. If there aren't any other questions, comments, I think I can squeeze in this last one. I picked a fairly simple, straightforward one. This is an 11-year-old male neuter Chihuahua mix. We got the right eye with the history of exophthalmos with moderately decreased retropulsion. And they noted a very hazy optic nerve with loss of the physiological pit. They did do a CT scan, which confirmed an intraconal mass. So back in the cone of the muscles in the back of the orbit there. And they also identified a little bit of mineralization within the mass on the CT scan. So they took out our globe, which we have here. And so indeed, we have this very kind of classic wedged shape as if it was in the cone there, tan mass that is on our posterior posterior globe centered around our optic nerve. So here is our cornea at the top. There's our lens and iris. And here's our mass. We cut it off so it would fit in the cassette very nicely here, but we can still see how it's really adhered to our posterior sclera here and really around the optic nerve. And it's probably even pushing the optic nerve in a little bit. And so we have a fairly monomorphic population of cells here that are neoplastic. They're right here again along the episclera, invading all the orbital fat and tissues here. Here's some skeletal muscle. And we've got these lovely little lobules here of these neoplastic cells that are often whirling on each other. Very, very cute swirly whirly pattern. They have indistinct cell borders, moderate amounts of eosinophilic cytoplasm. Nuclei are around oval with finely dispersed chromatin and a very prominent nucleolus. They're pretty bland looking if you compare those to those really wacky looking FDIM cells that Dr. Shaw showed earlier. So our anisocytosis and karyosis was pretty mild in this case. This mass does also have some evidence of osseous metaplasia. So we have a little bit of bone formation here, which would account for the little bit of mineralization that they were seeing on the CT scan. And so again, our optic nerve is a little pooched in. And if we look at our retina, there was no glaucoma noted clinically. But if we look at the retina here, we can see that there are no retinal ganglion cells. And that is most likely due to the compression of the optic nerve by the mass in the orbit, causing that retrograde loss of our ganglion cells. The rest of the eye was fairly quiet. There was maybe a little bit of epithelial hyperplasia to the cornea, which would go along with some exposure from that ophthalmia. And then this is just another section from the orbit here with a longitudinal section of our optic nerve, and we can see how squished and compressed that is from the mass, and then little pieces of bone. So this kind of features in a dog are pretty consistent here with an orbital meningioma. They're usually benign and don't typically metastasize, but given their sort of invasive nature, as you saw on the sections, it's really hard to get clean margins with this mass and when taking it out. So it's likely to eventually recur in the orbit. So it's a fun little case to finish this up. If there's no other questions, comments, then thanks for joining, and we'll see you guys in 2 weeks.
Yeah.
Thank you. We have a greater northern Galago coming tomorrow.
What is the Greater Northern Galgo?